Thank you, everyone, for coming out. We were joking this morning that it was going to be me lecturing to Ben for half an hour, and then I would sit down and he would lecture to me for half an hour. So it's exciting to see some people who are interested in the same stuff that we're interested in. I'm Jonathan Sonis. Ben White is going to be we're co-presenting this. We're both from Mass General in Boston, and really are passionate about patient experience and trying to do the right thing for our patients. Now it's not going to work again. I have to use the... No, let's see. That's all right, thank you. I'll stand up here for the moment. It's flashing. This one. That one. There we go. That one goes. Sorry for the red light late. So, what are our goals for the next 50 minutes or so? First is really understanding what's already out there in the existing literature to teach us about why ED patient experience is important, not just for our patients and their family members, but also for us and the staff that we work with, and then for our departments, our hospitals, and our health systems. Second is to help to sort of explain a little bit what that link is between high-quality clinical care for our ED patients and then high-quality ED patient experience. And then lastly, this is kind of the fun part, is just going through a list or like what are the things that you could go back and do tomorrow to improve your patient experience in your shop. And I like to start with a little bit of a disclaimer, only because probably not the people who chose to come to this talk on a Friday afternoon, but there are certainly folks among us who, when they hear the phrase patient experience, that sort of like the shade goes down. I'm not in this we're not the Marriott, right? We're here to like care for our patients. And I've heard somebody say, my idea of good patient experience in the ED is that the patient is alive at the end of the visit, right? And so we're not suggesting that you make your ED into the Ritz-Carlton. It's not about the thread count of the sheets. It's really just about doing the right thing for our patients and treating our patients and their family members the same way that we would all want to be treated or want our family members to be treated if we were ever in an emergency department. And hopefully we'll kind of prove that to you today. Why has there been such an increased focus in ED patient experience in the last 5 years or so? Multiple reasons, some more obvious than others. Reduces complaints and malpractice. We kind of know that. That's not rocket science, and we'll go through some of the data to show just how important that is today. Increases payment. That's important in a sort of environment where we're trying to get squeezed out of actually getting paid for the care we're providing. But really another more recent focus, especially in our current environment of really trying to combat burnout and improve the sustainability of the practice of emergency medicine, is that it really is important for ourselves, for our residents, for our staff, in terms of getting the satisfaction that we deserve out of our jobs. And obviously, and we'll show this again, it's actually better for our patients beyond just, oh, I had a nice experience. They medically do better. So this is not rocket science, like I said. Don't we already know this stuff? Isn't it common sense? It turns out maybe not. So Daniel Chen, who's at Boston University School of Medicine across town from us, and his colleagues did a really interesting study about 10 years ago. They looked at a group of medical students at BU School of Medicine, about 650 medical students, and then they administered us a validated empathy scoring tool called the Jefferson tool to the students sort of at points over time as they went through their medical school training, all 4 years, and they measured it. And so when I started reading this, I said, well, they probably come in with some baseline level of empathy, and then maybe it goes down a little bit while they're studying biochemistry for the first couple of years. But then once they get out into the wards, they realize this is why I'm doing this. The empathy skyrockets, and it's the exact opposite. So don't worry too much about the absolute numbers here, but just recognize that the different letters represent, so A, B, B, C represent statistically significant differences in the scores. So they come in with this baseline empathy level, and then for whatever reason, and these are measured at the end of the year, right? So at the end of their first preclinical year and then second preclinical year, it's sort of stable, goes up a little bit, maybe just because they're anticipating getting out there and getting to care for their patients. But this is where it gets really sad. So at the end of their third year, this is after they've been out on the wards now taking care of patients for a year, they have a significant drop. And then again, by the end of their 4th year, an even more significant drop. And this is when they're about to become doctors, right? This is when they're going to go out and actually start taking care of patients on their own. So there's something about intrinsic to actually practicing medicine, and we could all speculate about, and they do in this paper, about what some of these reasons are, that actually kind of beats the empathy right out of us. And lest we think, well, I work in an environment with a bunch of PAs or NPs, they don't experience the same thing. Actually, Ellen Mandel did a very similar study with a very similar tool and found the exact same result. There's something about getting out there and practicing emergency medicine that pulls empathy out of us. So with that background, it's like, all right, well, we need to be thinking about this. We need to actually improve things, among all the folks that we're working with. And I feel like we can kind of think of this in 3 major categories of why this should be emphasized. The first is it's better for our patients, and we mentioned this. And this isn't just it's better for them like, if you go out to dinner and have a nice experience, that's good for you. It's actually better for them in terms of quantitative, measurable outcomes. And I'll show you a couple examples of that. Hojat and colleagues did this study with about 30 family physicians and almost 1,000 of their patients. And they used a similar tool, a validated tool for empathy among this physician group. And then they measured basically diabetes control and lipid control over time. And these are odds ratios here. In the bottom in the red box, you see that they used they divided the physicians into 3 groups based on their scores. And compared to the reference group or the low group, those who were the high performers on that tool, significant differences, statistically significant differences in terms of control, so likelihood of having an A1C less than 7 and LDL less than 100. We see the same thing with hypertension control, similar study. This is interesting because this was done in Canada. In Canada, they actually, on their licensing exams, actually include a communication ability portion on their licensing exams. And so they used that as sort of the data for the physicians here, and then looked at hypertension control. They measured persistence with treatment, so basically just compliance with their antihypertensive regimens, and sure enough, those who had physicians who scored better on that section of their exams did better. And why is this, right? What is the cause? Levinson, about 9 years ago, in a Great Health Affairs article, this graphic is directly from the paper, and sort of summarized why this is happening, right? And so we communicate better, right? We have better communication skills with our patients, and that does a few things. Not only does it just improve their knowledge, right? So we tell them more and they listen to us more, but it actually it increases their self-efficacy and empowers them to improve their own self-care, right? And those things together are what lead to improved compliance with follow-up, with medication regimens, et cetera, and lead to these outcomes. So again, it's not rocket science, but when you actually see it written out like this, it's pretty powerful and sort of, to me at least, says, oh, we should be focusing on this. Our wallets. So this doesn't necessarily just mean yours and my wallet, but I put the asterisks there to represent that this is for our departments, for our hospitals, for our healthcare systems, for the healthcare system as a whole. Bad patient experience is expensive, and that's for a couple of reasons. The first and maybe more obvious is that risk management and malpractice lawsuits cost a lot of money, right? Whether it costs money out of our pockets or to insurers or whatever, it's expensive. This is a group of anesthesiologists in Boston that did this study about 15 years ago where they looked at patient experience data, right? So I think it was Press Ganey that they were using for patients who were discharged from the hospital for a 2-year period. And then they matched, in the system that we were part of this system, there's a centralized sort of risk management organization, self-insured organization. And so they matched to generalized complaints and then risk management episodes, so formal risk management episodes in malpractice lawsuits. And we all know what this is going to show, but the findings are actually pretty drastic. So black bars here are the bottom third performers for the physicians. White bars are the top performers. And then these are complaints per 100,000 discharges divided into complaints about care, like clinical care, and then communication. The first take-home point here is, well, okay, between 2 and 3 times more complaints in that bottom-performing group compared to the top performing group, which isn't surprising. But another really critical take-home point, I think, in this is that this is the overall, right? So this is A plus B equals C. Of the total number of complaints, look just how much more relate to communication than clinical care. So patients come in assuming that we're going to treat them correctly, we're going to give them the right medication, we're going to do the right procedure. That's like baseline, right? But they really notice the communication, and they care a lot about, does this doctor care about me, and are they communicating with me in a way that shows that? These are the actual formal risk management episodes. So in the middle here, general risk management, and then these are actual lawsuits, right? So these are actual malpractice lawsuits. We see the same pattern, right? So you're more likely to get sued if your patients don't like you because you're not taking the time to communicate with them and not expressing empathy. Hickson and colleagues, these are surgical patients. They looked at a group of over 600 patients over a 6-year period and basically just looked at unsolicited complaints that came into the department and then compared to malpractice lawsuits. And again, same message, right? Poor communication, poor experience, lots of complaints, leads to lawsuits, really painful for all of us, also very expensive. The other reason that patient experience really does now but will continue to, and in the future more, or more significantly affect us financially, is through actual reimbursement. Are you guys all familiar with HCAPs on the inpatient side? So it's the Hospital Consumer Assessment of Healthcare Systems. So this is a tool that's been used since 2012 for patients who are actually admitted to the hospital, a survey administered by CMS, and it's basically patient-reported experiences, right? And part of that relates to actual sort of what we would consider under the umbrella of patient experience. And CMS has, for Medicare and Medicaid reimbursement over the past several years, every year sort of ticked up a little bit how the total performance score, which is HCAPs contributes to that, either penalizes or incentivizes slightly higher or lower payment. And I think right now it's like at 2.5% of the total. So it's not insignificant, right? Sometime, either this year or maybe next year, CMS will release the EDPEC, Emergency Department Patient Experiences with Care Survey, which has a lot of the same kind of questions. So, and for all of these, we're using doctors as the example here, but it's nurses and doctors, right? So during this ED visit, how often did doctors listen carefully to you, explain things in a way you could understand, treat you with courtesy and respect? So these types of questions, and no matter if we think we're doing the right thing or not, how our patients respond to this will end up, assuming that they follow the same pattern as with HCAPs, affecting our reimbursement for, I'm sure most of us see quite a few Medicare and Medicaid patients. And last but not least, and this is the one that I think really deserves maybe even more focus, is that focusing on patient experience and focusing on treating our patients and their family members the way we would want to be treated is actually better for us. And I put this photograph of our residents up here because, burnout is so prevalent, right? We know that I think it's every year we're the top specialty for burnout, and sustainability is such a challenge in emergency medicine. And every year we see a new crop of residents come in who are so excited to have matched into this program in this in this specialty, bright-eyed, bushy-tailed, and I want to do everything we can possibly do to maximize the chance of that continuing for them, right? And treating our patients the right way is one way to do this. Tom Lee, who's an awesome internist and leader and now has a leadership role actually in Press Ganey, published this white paper in 2016 that I think really summarizes this really nicely. He said, physician burnout and patient experience are flip sides of the same coin. And I think for me that was a really helpful sort of paradigm or way to think about this, because when I first, if you view patient experience as like another task on the list for people to focus on, right? That's not going to help with burnout. That's going to make people sort of more frustrated, right? If it's like, make sure to do this, this, and this in EPIC, make sure to treat your sepsis patients this way, make sure to focus on patient experience, it's just another checkbox on a list. But when you think about the fact that treating our patients well actually increases our joy at work and increases our experience in our jobs, it's really not just another checkbox at all. And over in the literature, these are just a couple examples of papers in the last 5 years or so, we see that communication, improving patient experience decreases our own burnout, improves our workplace satisfaction, and this is across role groups outside of physicians as well. And this quote is from Dr. Lee's paper. The answer to physician burnout is not to reduce aspirations for the care that we deliver to our patients. It is to become more ambitious. And so I try to just keep this at the front of mind as I go through working on patient experience efforts in our own department. So with that, I will turn it over to Ben to go through in our second half here some really high impact and maybe in some ways low effort ways to improve things for all of us.
Thanks, Jonathan. Just given it's a small group of 5 interested individuals, do any of you have questions for Jonathan before we move into the phase 2? So we built this.
Do you have your microphone on?
I do. Okay. Can you all hear me? Y'all? All right, cool. We built this slide deck in this way so that everybody would have some practical opportunities to consider bringing back to their own EDs. As I know you just mentioned, you just went live with Press Ganey. So I hope that some of these interventions are of use to you. But I will just say that they span the gamut of the effort impact matrix. And so we've put some solutions in here that are a little bit lower impact, but also lower effort, and some that may require a little bit more in the way of resource use. We have neglected to mention reducing wait times, and that is on purpose, because we all know that communication and wait times are 2 of the most significant, and the literature demonstrates this clearly, influencers on patient experience. But this is sort of a separate topic and outside the scope of today's presentation. We should all be working on reducing our wait times and our door-to-doctor times, et cetera. But we're going to leave that alone for now. So number 10 is the one that I think many of us gravitate to in terms of administrative work, which is to think about improving the environment of care. It turns out that if you look at the literature, improving the environment of care does not have a significant effect size on patient experience, but it is, and in many departments, it tends to be a little bit of a lower hanging fruit intervention. And to the extent that your ED may be particularly cluttered and unclean in appearance, this is the whole you never get a second chance to make a first impression solution. And there is an interesting study that demonstrates that improving the environment of care through things like deep cleaning and privacy enhancements actually improves the perception of the quality of the medical care. So to the extent that your patients are going to be asked the questions that we underscored and the questions that are on the Press Ganey survey about the quality of care, if you can sort of bump that up with a lower resource intervention, it is worthwhile. The second sort of lower hanging fruit, no pun intended, intervention is to improve nourishment opportunities. There are a whole host of ways that you can do that, ranging in resource expenditures. There are some really interesting vending machines that can be purchased for not a whole lot of money. But one of the other sort of opportunities that many EDs have that we like to mention when we put this slide up is that it's not just having the food available, it's having the patients be able to receive that food, both in the way of having front-facing staff know that that food is available and it can be provided to patients, but also just working through some of the limitations that patients feel when it comes to not knowing whether or not they can eat. So the idea of patients being NPO by assumption when they come into the ED until it is clear that they can eat. So it's worth thinking through sort of how you operationally manage that as well. This is one of my favorites. I could talk about this for many minutes, but it is pretty straightforward. It's not rocket science. Improving patients' comfort makes the patient feel better and also improves their perception of your empathy and compassion. Some of the nicest thank you notes I've received have been patients that I've given a warm blanket to. And it is a little bit challenging that they don't really care or mention the quality of care, but giving a warm blanket is just such an easy thing to do, and it really, I think, is helpful for the staff member provider too. So if you don't have an easy way to allow your front-facing staff to provide things like blankets and pillows, it's worth thinking about this. We've actually just rolled out a new idea called a comfort menu. We haven't gathered any data about it yet, so maybe that'll be a next year's presentation. But it's just a list of things: earplugs, free Wi-Fi, things that patients can do to be more comfortable. The next is to think about patient perception. So there was a really interesting collection of articles that focused on the idea of the difference between actual and perceived wait time. Perception spans a whole host of different spheres, obviously, but providing multiple distractions can be really helpful. And we all see this in our normal everyday lives, right? That when we're waiting for any service, we're given opportunities to distract ourselves. And in the ED, for some reason, we are a little bit behind on that. But again, charging stations, Wi-Fi, most patients have smart devices of some kind that they can use to distract themselves as long as they haven't died out. So, and the limited literature about this does demonstrate an improved perception of wait time and the environment of care overall. This is one of those interventions that overlaps with actual quality of care. We all know that providing pain control improves the quality of care. But we have varying abilities to provide timely pain control in the ED. And the explicit approach to a code pain, prioritized pain control idea is really one worth considering from the perspective of the multiple positive effects it has on care. But to the extent that you're trying to think about various ways to improve your Press-Ganey scores, these data are pretty compelling, that even with a reduction in pain score of 2, so 8 out of 10 to 6 out of 10, not a significant reduction, you see a significant increase in the percentage of patients that note that they're satisfied with treatment and satisfied with the quality of care. And those are almost verbatim from the Press-Ganey survey. The next intervention is the communication toolbox. We have a few slides on this. This is obviously a very large topic of conversation. But explicitly dealing with the ways in which your front-facing staff communicate with patients is worth the time and the effort. And there are a host of different sort of ways to approach it. The literature is pretty clear, in addition to the burnout improvements on the staff side, that patients' compliance with the care plan improves, and the perception of the compassion and empathy on the side of the care providers improves. But there are multiple different models, and so I'm just going to go through 3 so you can kind of think about which might fit best in your ED. ADED is probably the most popular. We weren't huge fans of it, and there's overlap in these models, by the way. So things like introducing yourself you'll find in most of the models, acknowledging what the patient is there for or their weight, a whole host of different sort of ways to acknowledge the patient as a human. Those sort of humanistic traits are sort of present throughout most of these communication models. But things like thanking the patient at the end, some folks really like that. It seems a little bit odd to me, especially given the way our ED is set up. So another way to think about communication is, what is it that you're really trying to communicate? And one of our psychiatrists at MGH has a really, really good YouTube video on empathy. This is a model she developed, Helen Reese. And it doesn't translate well in terms of the lecture format, in that each one of these details really needs to be developed a little bit more. But the idea is that you can codify empathy and think through ways in which you might be able to train your staff just to think about maybe 1 or 2 of these aspects that they may not be focusing on. So eye contact, for example. And if you're interested, again, the YouTube video from Helen Reese is really great and quite compelling. And then there's ways that you can spend money through her company to train your staff if you're interested. And I have no disclosures from that perspective. So then finally, there's the eye care model. And this is one we created, combining a number of different models, and is our sort of personal favorite. But I'll just put it up here and walk through it for you, just so that you can draw on the components you might like. One of the ways in which eye care has been particularly successful for us is that it's quite simple, and it sort of dovetails nicely with most providers' practice. So most of the time when we walk into the room, there is an opportunity to introduce ourselves. And I say opportunity because it is not uncommon that we forget to introduce ourselves. And so calling this out explicitly and saying, just make sure you introduce yourself to the patient goes a long way. And one of the things that we've sort of learned from this is it's not just introducing yourself to the patient, but if there's family members in the room, making sure you include the family members as well. Collaborating is an idea of sort of developing that empathetic, humanistic relationship with the patient and making sure that they and you are on the same page, using phrases like "and" as opposed to telling patients that they can or cannot have a certain thing. Acknowledging the patient's sort of discomfort, broadly defined, whether that be discomforts and frustrations from weights or discomforts from their medical condition, is a nice way to establish a further connection with the patient and allow them to sort of open up to you in a way that they may not otherwise. This is, I think, and I'd be interested in your thoughts on this, but this is one of the more challenging things to teach, and it's probably an area of further focus for us. And then reflectively listening. One of our other slide decks has a really interesting study in it in which if you let patients speak without interrupting them, they speak for a certain period of time, and that period of time is, anyone want to take a guess? Yeah, about a minute, just over a minute. And that was not what I would have assumed, and I'm still working on this. I was not particularly very good at letting patients just speak and tell their story, but letting the patient tell their story and then reflectively sort of parroting that back to them in some way really helps the patient know that you understand what they're saying and that they are getting a collection of care plans that are aligned with their values. And then finally, this is a huge one for us, setting expectations. This is present in a lot of different communication models. But there is an equation for happiness, that happiness equals reality minus expectations multiplied by perspective. And we have many opportunities in our shop, and I would imagine a number of you do too, for setting expectations appropriately and making sure that patients know that they are likely to have a different experience in our department than they may have been expecting initially. The next intervention, and this one is incredibly straightforward and kind of compelling in a lot of ways, is to sit down. And it is literally encouraging your providers and front-facing staff, patient-facing staff, to sit. There are some logistical issues with this, and if anybody is having trouble finding ways to sit, we have tried a few different options. There is a stool that is reasonably priced for a healthcare environment that rolls until you sit on it, and then it doesn't move anymore. That's the one we've sort of focused on, but there's fold-down chairs that you can install in the wall. We went with one that was injurious, so we have removed it. But it's worth just thinking about how you might facilitate this in your ED for, again, very low cost. And what you find, and again, this is kind of the part of it that's so interesting, is that if you sit, your patients think that you have spent more time with them. This is a study of 127, I think, post-op patients. And while the graphic is not particularly interesting to look at, the results are in that if you are standing in the room for a minute and 28 seconds, the patients perceive you to have been in the room for 3 minutes and 44 seconds. And if you sit and spend even less time in the room, you get a 500% gain on that investment of time. And even more so, the positive and negative comments distribution changes significantly. So physicians that were standing had a distribution of 60-40, positive to negative comments, and physicians that were sitting had 95% positive comments and almost zero negative comments. So that's a whole lot of benefit for a simple change in body posture. And if there was one sort of thing that I would suggest facilitating in your department if you haven't yet, it's just asking folks. Obviously, the introducing part is important too, but after introducing yourself to the patient, sitting down and chatting with them this way. It's not a big deal. And we'd be happy to talk to anybody more about details of our experience if you have logistical or operational questions in that regard. The next intervention is discharge teaching. Again, this could be a whole long collection of slides, but the point is just that it is really important to finish strong. And it allows you not only to improve the care of the patient, broadly defined, but also to allow the patient to have more positive sort of opinions of their most recent interaction with the healthcare system, and improves follow-up compliance. And so there's a number of ways to do this. There's teaching about the actual act of discharge teaching. There's EMR improvements that you can try, and there's a whole host of different interventions. One of the ones that we've had a little bit of positive success with is just creating a pamphlet. And pamphlets have kind of waxed and waned in terms of their utility in our department, but this was a particularly sort of perfect subject matter to create a pamphlet and allow a patient to just sort of flip through that while they're thinking about their discharge. There are a whole host of operational constraints that we've had with respect to this, but at least the idea overall is a good one. This is another one of my favorites, largely because of the impact size and because it's another intervention that both has the potential to improve the patient's health care and also all of the other sort of components of patient experience and scoring that we care about broadly as ED physicians. So the idea is that you just call patients back. And it doesn't have to be a nurse. Many of the models are nursing callbacks, but it can be a doctor or a volunteer. And when this was studied in 2013, demonstrated a 20% improvement in likelihood to recommend and an improved perception of care. And the reason this particular metric is important is that when hospital leadership looks at your Press-Ganey scores from the ED, very often they are looking at these summative measures, right? And Jonathan went through some of the EDPEC questions that we can use to more granularly try to improve various metrics that we're interested in. But when the bean counters are looking at your ED, they look for those big summative measures, like did you have a good experience with care overall, and are you likely to recommend this ED to your friends and family? And so this is a really good way to sort of know that you're going to be able to improve that. And at the same time, it allows you to collect information on interventions that you've made. So one of the ways in which we use our nurse callback program is that when we make a patient experience intervention, we add a question to the nurse callbacks litany of questions and have them say, did you find this or that helpful, or do you even remember that as a part of your experience? And that, again, this is just another emphasis on the importance of the increase in likelihood to recommend from a nursing callback program. But that brings us to our last intervention, which is realistic expectations. It's never 30 minutes from this point, right? So just like, and Jonathan uses the Cheesecake Factory, anytime you go out to a restaurant and the hostess tells you it's going to be 45 minutes, if it's 35 minutes, you're stoked. Again, happiness equals reality minus expectations. If it's 46 minutes, you Yelp 1 star or whatever people do to rate restaurants these days. So it is worth thinking about how you're going to provide time estimates to your patients and perhaps being a little bit generous with those. And then, when this is studied, it's demonstrated to reduce frustration and improve expectations. So this is our signage that we've put up. It took about a decade, and that is not hyperbole, to get folks on board with just owning our turnaround times and putting them on a sign. This is a little bit generous. We had part of what facilitated this is that we were able to create a robust data set of median turnaround times, so we knew what our median turnaround times were, and we added a bit and rounded up as it were. But this was one of the signs where we asked our nursing callback program to ask, did you see the signs and were they helpful? Folks didn't really see the signs that well, but those that did thought they were helpful, so then we increased the size. And that sort of iterative, not particularly rapid, but rapid cycle change is one of the things that you can sort of do as, yes, question? So that is a great question. We have a split flow model in our ED, and half of our patients, mostly middle acuity patients, move through a evaluation and then internal waiting room system. And these signs were put in the internal waiting room area. We have a whole sort of collection of signage that we've built now. That slide's not in this slide deck. I'm happy to share them with you if you'd like, that sort of guide a patient through their progression through the ED. But this sign is in the internal waiting area. And so, again, this is the summary of the various intervention opportunities that we think might be helpful. And we're happy to share more information with you, especially if you're thinking about utilizing any of these. And I don't think we have the next slide that says questions, but we're going to open it up for questions.
And I would just add, too, for the eye care model, which is the one that was developed at MGH, Emily Aronson, who actually had a baby yesterday, so couldn't be here with us today to give this talk, but she and a quality nurse colleague sort of developed that model, and I know for a fact that she's very happy. We're very happy to share that. I saw some people taking photos of that, and there are a bunch of specific phrases sort of built into that model that are really helpful in terms of training it, because all you have to do is just remember that phrase. So feel free to reach out, and I can get that up to you.